Welcome to this episode, where we're diving deep into pediatric musculoskeletal infections, tumors, and autoimmune disorders. It's a complex area, but crucial for clinicians managing children with bone and joint diseases.
Absolutely. We're going to unpack infections like osteomyelitis, septic arthritis, and skeletal tuberculosis, then move into pediatric bone and soft tissue tumors, including osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. Finally, we'll explore autoimmune conditions like juvenile idiopathic arthritis and systemic lupus erythematosus.
Right, so let's start with infections of bones and joints. Osteomyelitis is a good place to begin. It's an infection of the bone that can happen at any age, but is most common in children under 10, especially those younger than 2.
Yeah, and the incidence in developing countries ranges from about 1 to 13 cases per 100,000 children. The usual sites affected are the foot, femur, tibia, and pelvis.
The causative organisms vary with age and underlying conditions. Methicillin-sensitive and resistant Staphylococcus aureus are the main culprits, along with Group A Streptococcus. In newborns, Group B Streptococci and Enterobacter are more common. Children with sickle cell disease often get infections from Salmonella and S. aureus, and sexually active adolescents might have Neisseria gonorrhea.
Don't forget Kingella kingae, which is increasingly recognized as a major pathogen in kids under 5.
Good point. Now, osteomyelitis is classified into acute hematogenous, exogenous, subacute, and chronic types. Acute hematogenous lasts less than 2 weeks and results from bacteria traveling through the bloodstream, often from infections like upper respiratory tract infections or abscessed teeth.
Exogenous osteomyelitis, on the other hand, comes from direct inoculation. Think puncture wounds, open fractures, or surgical contamination.
Subacute lasts less than 3 months and is caused by less virulent microbes, often forming a Brodie's abscess, typically in the tibia.
And chronic osteomyelitis is a progression from acute, lasting more than 3 months, characterized by dead bone loss, drainage, and sinus tracts.
The pathophysiology is fascinating. Bacteria adhere to the bone, causing a suppurative infection with inflammation, edema, vascular congestion, and thrombosis of small vessels. This leads to bone destruction and abscess formation.
Right, and the dead bone, or sequestrum, gets surrounded by new bone called the involucrum. Sometimes, sinus tracts form, draining pus through the soft tissue to the skin.
The age of the patient really influences how the infection behaves. In infants, blood vessels cross the growth plate into the epiphysis and joint space, so joint infection is more likely.
Whereas in children older than 1 year, the growth plate acts as a barrier, containing the infection and making joint involvement less common unless the infection is intracapsular.
Adolescents with closed growth plates have poorer containment, so the joint is more vulnerable. Adults have tightly attached periosteum, so rupture and sinus tract formation are more common.
Clinically, acute osteomyelitis presents with systemic signs like fever, irritability, lethargy, rapid pulse, and dehydration. Locally, there's tenderness, warmth, swelling, pain, especially on movement, and the limb is often held in semiflexion.
Infants may also have adjacent joint effusion. The tricky part is that symptoms can mimic other conditions like arthritis, leukemia, or sarcoma.
Diagnostics rely heavily on cultures: blood, aspirated pus, joint fluid, and skin samples. Bone biopsy is reserved for cases where cultures and imaging don't align.
Lab markers like leukocytosis, elevated C-reactive protein, and erythrocyte sedimentation rate support the diagnosis. Imaging-wise, radiographs only show changes after 2 to 3 weeks, so early imaging uses ultrasound for collections and MRI, which is the gold standard.
Bone scans can help locate multiple sites or chronic infections, but CT is less commonly used diagnostically.
Treatment starts with empiric IV antibiotics after cultures. Nafcillin or clindamycin covers MSSA, but with rising community-acquired MRSA, vancomycin may be necessary.
Therapy is prolonged, anywhere from 6 weeks to 4 months, depending on symptom duration, response, and organism sensitivity. Stable patients might switch to oral antibiotics.
Monitoring for side effects is critical: hematologic, renal, hepatic, ototoxicity. Probiotics can help prevent antibiotic-associated diarrhea.
Surgery is reserved for cases not responding to antibiotics, persistent abscesses, joint spread, or infections involving hardware. There's debate about timing. Some advocate early sequestrectomy and drainage to prevent chronic infection.
Nursing care focuses on pain management, limb immobilization, avoiding weight bearing during the acute phase, and careful IV therapy monitoring. PICC lines are common for long-term antibiotics.
Nutrition is important too. High protein to support healing. Once acute symptoms subside, physiotherapy helps restore function.
And psychosocial support is essential, given the prolonged treatment and impact on the child and family.
Moving on to septic arthritis, it's a bacterial infection of the joint, with hips, knees, and ankles accounting for about 80% of cases.
The infection usually spreads hematogenously, but can also come from adjacent cellulitis or osteomyelitis, or direct inoculation from trauma in about 15 to 20% of cases.
S. aureus is again the most common pathogen, with community-acquired MRSA on the rise. Newborns may have Group B strep, E. coli, or Candida. Children between 2 months and 5 years often have S. aureus, Streptococcus pyogenes, Streptococcus pneumoniae, or Kingella kingae.
Older children and adolescents tend to have S. aureus and S. pyogenes, and sexually active teens may have Neisseria gonorrhoeae.
Clinically, septic arthritis presents with severe joint pain, swelling, warmth, and sometimes erythema. Hip infections are surgical emergencies because of the risk of compromised blood supply to the femoral head.
The child resists any joint movement and may have systemic symptoms like fever, malaise, headache, nausea, and irritability.
Diagnosis involves joint aspiration for gram stain, culture, including specific cultures for Haemophilus influenzae and N. gonorrhoeae, and leukocyte count. Blood cultures, CBC, and inflammatory markers are also important.
Imaging starts with X-rays showing soft tissue swelling, but MRI and CT provide detailed views of cartilage loss, erosions, and joint narrowing. Ultrasound is useful for detecting effusions.
Treatment is IV antibiotics guided by gram stain and clinical presentation. The role of serial aspirations is debated.
Pain management is crucial, especially for large joints like the hip. Surgery may be needed if there's penetrating trauma or foreign bodies.
Physiotherapy helps prevent contractures in immobilized joints. Nursing care parallels that of osteomyelitis.
Skeletal tuberculosis is less common in North America, but important in endemic areas. It's usually acquired via lymphohematogenous spread during primary infection or from chronic pulmonary TB.
The vertebrae are most commonly affected, leading to tubercular spondylitis or pot disease, which involves vertebral body destruction, disc erosion, kyphosis, and cold abscess formation.
Symptoms are insidious, persistent or intermittent pain, joint swelling, stiffness. Fever and weight loss are uncommon.
Diagnosis requires a history of TB exposure, positive tuberculin skin test, though that's not diagnostic. Radiographs show bone loss, deformity, and gibbous formation.
Ultrasound and CT-guided biopsy help isolate Mycobacterium tuberculosis. Treatment involves combined anti-tubercular chemotherapy with isoniazid, rifampin, and pyrazinamide.
Immobilization, casting, and fusion may be necessary for spinal or hip involvement. Nursing care is similar to osteomyelitis and septic arthritis.
Shifting gears to pediatric bone and soft tissue tumors, about 90% of primary malignant bone tumors in children are osteogenic sarcoma or Ewing sarcoma.
Osteosarcoma accounts for 56% of cases, with peak incidence around 15 years and a male predominance.
These tumors cause localized pain, which can be severe or dull, sometimes mistaken for growing pains or trauma. Pain is often relieved by flexing the limb, which relaxes muscles over the periosteum.
A palpable mass is common, and systemic symptoms like fever or spinal cord compression are more frequent in Ewing sarcoma.
Osteosarcoma arises from bone-forming mesenchyme producing malignant osteoid, mostly in the metaphysis of long bones, especially the distal femur, but also humerus, tibia, pelvis, and jaw.
Radiographically, it shows a classic sunburst pattern from radial ossification in soft tissue.
Treatment involves surgical biopsy followed by limb salvage or amputation. Limb salvage is preferred when negative margins and joint preservation are possible.
The Van Ennes rotationplasty is a unique limb salvage procedure for distal femur or proximal tibia tumors, where the affected bone is removed, and the ankle is rotated 180 degrees to function as a knee.
Hemipelvectomy and forequarter amputation are options for pelvic and upper humerus tumors, respectively.
Preoperative chemotherapy is standard to shrink the tumor and improve surgical outcomes. Chemotherapy is vital, used before and after surgery, and thoracotomy may be needed for pulmonary metastases.
Prognosis has improved significantly, with about 78% survival in non-metastatic disease.
Nursing care focuses heavily on psychological preparation, especially for amputation. Honest communication is key, addressing questions about prostheses and phantom limb pain.
Phantom limb pain can be managed with medications like amitriptyline, gabapentin, and pregabalin, and nerve blocks before surgery may help reduce its occurrence.
Early discharge planning includes physiotherapy and community support. Canada's CHAMP program is a great resource, providing peer support and education.
Ewing sarcoma is the second most common malignant bone tumor, arising in marrow spaces, affecting the diaphysis of long and trunk bones like pelvis, femur, ribs.
Radiographically, it shows the Codman triangle, indicating periosteal elevation.
Treatment combines intensive radiotherapy and chemotherapy with surgery for vertebral and rib tumors. Limb salvage is possible, but amputation may be needed if radiotherapy causes deformity.
Psychologically, families often find Ewing sarcoma less traumatic than osteosarcoma because the limb is preserved.
Nursing care includes preparing families for diagnostic tests like bone marrow aspiration, managing radiotherapy, skin reactions, and chemotherapy side effects.
Rhabdomyosarcoma is the most common soft tissue sarcoma in children, arising from embryonic mesenchyme, with 3 subtypes: embryonal, alveolar, and pleomorphic.
It can occur almost anywhere, but the head and neck, especially the orbit, are common sites.
Symptoms vary by site. Orbital tumors present early with proptosis and eye movement loss, while retroperitoneal tumors are often silent until advanced.
Diagnosis involves imaging with CT or MRI, metastatic workup with chest CT, bone scan, bone marrow biopsy, and sometimes lumbar puncture for parameningeal tumors.
Biopsy or surgical resection confirms diagnosis. Prognosis depends on staging, with over 80% survival in non-metastatic disease using multimodal therapy.
Treatment includes chemotherapy, radiotherapy, and surgery when feasible, avoiding radical surgery if the tumor is chemosensitive.
Nursing care parallels other cancers, focusing on support through diagnostics and therapy and monitoring for site-specific complications.
Now, on to autoimmune disorders. Juvenile idiopathic arthritis, or JIA, is a chronic autoimmune arthritis starting before age 16, with peak onset between 1 and 3 years.
It affects girls twice as often as boys, with about 3 in 1,000 children diagnosed annually in Canada.
The cause is unknown but likely involves immunogenic susceptibility plus environmental triggers like viruses. Genetic risk factors include HLA class 1 and 2 genes, PTPN22, and IL-2 RACD25.
Pathophysiologically, chronic synovial inflammation leads to joint effusion, cartilage erosion, fibrosis, adhesions, and ankylosis if untreated.
The clinical course is variable. About a quarter of children achieve remission off medication.
Classification by the International League of Associations for Rheumatology includes systemic arthritis, oligoarthritis, and polyarthritis, plus subsets like psoriatic and enthesitis-related arthritis.
Diagnosis is by exclusion, requiring arthritis in 1 or more joints for 6 weeks or more, onset before 16, and ruling out other causes.
Labs may show variable ESR, leukocytosis in systemic JIA, and anti-nuclear antibodies, which aren't specific but predict uveitis risk.
Imaging starts with plain radiographs showing soft tissue swelling, progressing to osteoporosis, joint space narrowing, and erosions.
Eye exams are essential to detect uveitis, especially in ANA-positive young girls with oligoarthritis.
Treatment goals are pain control, preserving joint function, minimizing inflammation, and promoting normal growth.
Medications include disease-modifying anti-rheumatic drugs like methotrexate, biological agents such as TNF inhibitors, NSAIDs as adjuncts, and corticosteroids for severe cases.
Biologics require TB screening and infection risk education. Therapy is stepped up based on disease activity and response.
Nursing care involves pain relief through meds and non-pharmacological methods, promoting nutrition, sleep, exercise, and encouraging school attendance with accommodations.
Facilitating adherence through education on meds, splints, and toxicity signs is critical, as is psychosocial support for the child and family.
Heat therapy and pool exercises help maintain joint mobility, and nighttime splints prevent deformity.
Families need support addressing prognosis, finances, and social impact, with referrals to social workers or support groups as needed.
Finally, systemic lupus erythematosus, or SLE, is a chronic autoimmune disease causing multi-system inflammation and damage.
It affects about 1 in 1,000 Canadians, with 10 to 20% diagnosed in childhood, typically around 11 or 12 years old.
There's no gender difference under 15, but genetic predisposition plus triggers like UV light, estrogen, pregnancy, infections, and medications play roles.
Ethnic disparities exist, with different lupus phenotypes and severity among groups.
Clinical manifestations are broad. Constitutional symptoms, cutaneous rashes like the malar rash, musculoskeletal issues, neurological, renal, pulmonary, hematological, and vascular involvement.
Diagnosis requires at least 4 of 11 criteria, including malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal or neurological disorders, hematological abnormalities, immunological markers, and anti-nuclear antibodies.
Treatment balances controlling inflammation and minimizing treatment morbidity. Corticosteroids are mainstay, tapered to lowest effective dose.
Hydroxychloroquine helps with rash and arthritis, NSAIDs relieve symptoms, and immunosuppressives like cyclophosphamide, mycophenolate, azathioprine, and methotrexate manage severe organ involvement.
Supportive care includes nutrition, rest, and exercise, with strict sun protection to prevent exacerbations.
Nursing focuses on education about disease, medication adherence, recognizing flares, sun protection, and psychosocial support.
Coordination of care and referrals to social workers or support groups are important, as is encouraging medical alert identification and prompt care during illness or procedures.
To wrap up, osteomyelitis and septic arthritis require prompt diagnosis and prolonged, carefully monitored antibiotic therapy.
Pediatric bone tumors demand multidisciplinary management balancing limb preservation and oncologic control.
And autoimmune diseases like JIA and SLE are complex, with variable courses needing tailored immunomodulatory therapy and comprehensive nursing support.
Integrating clinical, diagnostic, therapeutic, and psychosocial aspects is key to optimizing outcomes in these challenging pediatric conditions.
Thanks for joining us in this deep dive. We hope this discussion adds depth to your understanding and practice.
Take care.